Hello everyone and welcome to the Sprint and Diabetes session of Hypertension Canada Sprint Expert Exchange. I'm Angelique Berg, CEO of Hypertension Canada. Hypertension Canada is the only national nonprofit organization dedicated solely to the prevention and control of hypertension and its complications. Through our professional network of Canada's leading multidisciplinary experts, Hypertension Canada pursues its mission through the advancement of research, public and professional education and advocacy. And we produce Canada's Hypertension Clinical Practice Guidelines, for which we're best known, which are evidence-based, annually updated, and rigorously reviewed. And we offer accredited training to help keep healthcare professionals at the leading edge in hypertension management. So that's why today we're kicking off our Sprint Expert Exchange, which addresses new guidelines developed in response to the Systolic Blood Pressure Intervention Trial, or SPRINT. It has resulted in changed blood pressure targets in some populations. Our series panelists join us as independent experts rather than representatives of Hypertension Canada and will provide perspective and context for the most challenging clinical judgments that professionals make in their practices every day. We hope you enjoy this first expert exchange, and we thank you for being with us. It is my pleasure to begin by introducing today's moderator. Dr. George Dresser is an associate professor and an active clinician in general internal medicine and clinical pharmacology at Western University. He chairs Hypertension Guidelines Committee on Pharmacotherapy for hypertensive patients without compelling indications and has been at the center of this year's Sprint-related guidelines update. And he helped to develop and lead this Sprint Expert Exchange series. I will now turn the floor over to Dr. Dresser to introduce the other panelists and kick off today's session.
Hello everyone, I hope you can see me. It's my pleasure to be here. Thank you for joining us. It's my pleasure to introduce our expert panelists for today, and you should be able to see disclosures on the slide. Dr. Phil McFarland is a clinical investigator in the Division of Nephrology at St. Mike's Hospital in Toronto. He's an assistant professor at the University of Toronto. He's a member of Hypertension Canada Guidelines Committee and also participates in guidelines groups for the Canadian Diabetes Association and for the Canadian Society of Nephrology. Phil, do you want to just give us a wave?
Sure. Hi guys. Hi everybody.
Dr. Rabi will be joining us. I don't know if she's made it on the line yet. She is a clinical endocrinologist and an associate professor in the Department of Medicine at the University of Calgary. She chairs the Hypertension Canada Guidelines Committee and also participates in guidelines groups with the Canadian Diabetes Association. Has Doreen joined us yet? All right, well, we'll go on to Sheldon. Sheldon Tobe is a nephrologist at Sunnybrook Hospital. He's a professor of medicine at the University of Toronto and the Heart and Stroke Foundation Northern Ontario School of Medicine Chair in Aboriginal and Rural Health Research. He is also a director of Hypertension Canada and a member of the Hypertension Canada Guidelines Committee. Sheldon, do you want to give us a wave?
Hey, George. Good morning.
So I'd like to introduce the agenda today. And if we want to flip the slides over. Today we're going to be, we've already talked a little bit about what is Hypertension Canada. I will introduce the Systolic Blood Pressure Intervention Trial, or SPRINT trial. We're going to talk about what changes have been made to Hypertension Canada Guidelines as a result of SPRINT. And the key topic for today is really related to the issue of diabetes. And then we'll have some time for audience questions and answers. You can submit your questions, and we will hopefully have some time at the end to deal with them. So the specific learning objectives are that we want to explain that patients with diabetes were specifically excluded from the SPRINT trial. We are going to discuss the updated recommendation for the 2016 Hypertension Canada Guidelines related to SPRINT. And we're going to talk about applying the updated recommendation in practice and we'll get some expert opinion in terms of how this will all work, and I've got some questions for our expert panel at the end. So go on to the next slide. So the SPRINT trial was a trial published in the New England Journal of Medicine this past November. It is a trial looking at the effect of intensive systolic blood pressure control to less than 120 millimeters of mercury versus standard control, which for this trial was less than 140 millimeters of mercury. It was a good-sized trial. There were 9,361 patients. They were largely hypertensive patients, as we would consider them. Importantly, they did not have diabetes at the start of the study. They did not have stroke. And they were followed for a mean of 3.26 years before the study was stopped prematurely because of a statistically significant mortality difference favoring the intensive therapy arm of the study. So if you go to the next slide. So the major inclusion criteria for the SPRINT trial were that all patients had to be over 50 years of age. Inclusion blood pressure was anywhere between 130 and 180. Patients were allowed to be on medication at entry to the trial. The average number of medications was 1.8 actually in the patients who were entering the trial. And then the patients, importantly, had to have at least one additional cardiovascular risk factor. They had to have established clinical or subclinical cardiovascular disease. They had to have chronic kidney disease. They had to have a calculated Framingham score of at least 15%, or they had to be over the age of 75 years. And the breakdown in the patients who were included in the trial was about a third chronic kidney disease, a third over the age of 75 years, and then a third of them had the cardiovascular risk score over 15%. There were some very important exclusions. Patients who had had a clinical stroke in the past were not included. Patients with established diagnosis of diabetes were not included. All patients were stood up, and if their systolic blood pressure was less than 110 millimeters of mercury standing, they were not included. And then there were a number of other exclusions related to either the need for specific therapies or perhaps difficulty tolerating the algorithm of care. The patients were randomized in a one-to-one fashion to the intensive treatment goal blood pressure of less than 120 or to the standard treatment goal of less than 140. Next slide. So in the top right corner of this slide, you can see the blood pressure achieved. And what you can see in this slide is that within about 3 months, the blood pressure had dropped from approximately 140 systolic down to about 120 systolic in the intensive treatment arm. And in the standard treatment arm, the blood pressure had dropped from a mean of 140 down to a mean of 130. There was very early separation in the blood pressure. And in the larger Kaplan-Meier curve, you can see the mortality data. So starting at about 2 years, the mortality curve started to separate, and by the average of 3-year mark in this trial, the mortality difference was large enough favoring the intensive treatment group that the Data Safety Monitoring Board felt they could no longer recommend that the trial be continued. You go on to the next slide. So the SPRINT primary outcome was a composite outcome of clinical coronary events, clinical cerebrovascular stroke events, heart failure, and then cardiovascular mortality. And what this plot shows is the outcome according to various predefined subgroups. So overall, the hazard ratio for the primary outcome was about 0.75, favoring intensive treatment. They stratified according to chronic kidney disease, and again, there was no heterogeneity. They stratified according to age over and under 75, And while there wasn't heterogeneity statistically, it actually looks like the group over 75 perhaps got even more benefit from intensive therapy than the group who were under 75, which is very interesting. They stratified according to sex, and there was no significant difference. No significant difference according to race, according to presence or absence of previous cardiovascular disease, and then according to enrollment blood pressure. And I think the last plot at the bottom of this slide is interesting. What you can see here is that approximately a third of the patients had enrollment systolic blood pressures between 130 and 132. So a fair number of patients in this trial had reasonably well-controlled blood pressure at entry to the trial. So if you go on to the next slide. So this slide highlights a number of Hypertension Canada guidelines which are relevant as we think about this data from the SPRINT trial. So first of all, the hypertension guideline that a target blood pressure of less than 140/90 should be attained in most hypertensive patients that's still true today. The SPRINT trial adds in bold that in high-risk patients, a systolic target of less than 120 should be considered. Our current diabetes recommendation that in persons with diabetes, a blood pressure of less than 130/80 is recommended stands. And importantly, we don't recommend that all these patients necessarily receive drug therapy. In fact, we say that this lowering or targeting of blood pressure can be done using lifestyle modification and, if necessary, medication. So if you flip on to the next slide. So now it's a chance for our panelists to say a few things. And really, these questions came from the top of my head, I guess. But I think I'd like to get maybe an introductory comment from each of you. And I think maybe a reasonable place to start would be if you each want to take a crack at the first question, which is, given that patients with diabetes were excluded, does SPRINT have anything to say for people who are currently living with diabetes? So in no apparent order, whoever wants to jump in there can maybe add their 2 cents, and we'll get your opinion.
Okay, so George, can you hear me okay?
Yes.
Okay, perfect. So I guess maybe I would just add to your introduction, we keep mentioning that people with diabetes are excluded, which is true, but the NIH were running 3 big concurrent blood pressure trials, SPRINT, HALT PKD, which was a blood pressure study in people with polycystic kidney disease, and ACCORD BP for people with diabetes. So people with diabetes were, yes, they were excluded from SPRINT, but they were directed over to the ACCORD trial. And just to remind people that when ACCORD was completed, the overall results were moving in the right direction, but not statistically significantly so. There were small absolute but statistically significant benefits in terms of a reduction in stroke, although there weren't a particularly large number of strokes in ACCORD, and a reduction in progression of early kidney disease as tracked by albuminuria. So those were the statistically significant results from ACCORD. Overall, I believe the rate reduction was around about 11–12%, and did not reach a P of 0.05. But the major criticism of ACCORD with respect to its interpretation was that they had an event rate that was much lower than they had anticipated. They had expected a particular event rate, and they only got about half as many cardiovascular events as they had planned. And so the trial, although initially felt to be properly powered, ultimately proved to be underpowered, and so that's made the interpretation difficult. So I just wanted to bring up ACCORD before we cycle back to how SPRINT talks to diabetes.
Excellent. Thank you. Sheldon, Doreen?
And thanks for that, Phil. That was an excellent review. And a comment I'll make is that internationally, clinical practice guidelines groups in the last 5 years have been moving their thresholds for treatment higher. And the best example of that is JNC 8, where the threshold for treatment for people over age 60 was moved up to 150 over 90. And for diabetes in particular, that target, the threshold, was moved up to 140 over 90 for people with diabetes. And one of the things I think that Sprint helps us with for managing people with diabetes is it just vindicates and confirms our approach with the Hypertension Canada Guidelines, that our target for people with diabetes is to aim for less than 130 over 80. And Sprint tells us that we are certainly heading in the right direction. And I really think that that helps to confirm that we have been on the right pathway all along. Doreen, what are your thoughts?
Yeah. Well, it remains controversial. The idea of vindication, I suppose, is an interesting one. But certainly there are other jurisdictions who did drop the 130 over 80 in favor of higher targets in people with diabetes. We did not. And Accord, as I mentioned, it had some positive signals in it. And I just would remind people that we got to 130 over, we got to a systolic target of 130 based on the ABCD normotensive study, which also was negative overall, but had positive results for stroke and progression of kidney disease, similar to Accord. So one of my sort of thoughts over the years has been, if those were the outcomes that drove us to 130, why don't they drive us to 120? And if we don't like those ones, why don't we go back up to 140? But having said that, the fact that we didn't move it sort of helps now, because if we're going to, I think what George's challenge to us is to really try to reconcile the idea that we could have people with hypertension who have higher cardiovascular risk aiming to 120, but leaving one of the highest risk populations, that being people with diabetes, at 130. Seems to be sort of, on the surface of it, seems to be an odd proposal, and I think that's what George's challenge to us is, to try to answer to that.
Doreen, I noticed that your microphone seems to be muted. I don't know if you can unmute that and give us an opinion. Oh, there you go. I'm not getting any audio feed. Okay, it seems like we're having a little bit of difficulty with Doreen's microphone. I don't know whether she was having some technical issues. Maybe while we see if we can sort that out.
And I'll chip in about the technical issue. That I had to reboot my computer to get my audio to work this morning. And just about the diabetes, and to continue on from what Phil was saying, is that our target is a target of less than 130. So I would point out that less than 120 is consistent with less than 130, and we know that lowering blood pressure, that the lower achieved blood pressure is associated with better outcomes. So as we're lowering our patients with diabetes blood pressure, and we end up with a blood pressure systolic of 120 or 122 or even 118, Accord tells us that we will help to lower stroke, but the new Sprint study gives me confidence that this is a good thing for our patients.
Great. Actually, on the heels of the publication of Sprint, there was sort of a small meta-analysis combining the data from Sprint and Accord. Do you think it's fair to do that? Are there differences that make that problematic, or is that a fair comparison?
So I would have concerns about that type of a meta-analysis. There are tests within a meta-analysis to check for statistical heterogeneity, meaning that these the populations of these trials and how the intervention played out in these trials, whether were they similar in the studies that are being combined, or did they play out differently? And the problem with that approach is that those are statistically low-powered tools, so that the populations have to be quite different, and the way that the intervention plays out in those populations has to be quite different before a meta-analysis would fail the test for heterogeneity. But I like to apply the sort of the face value test first. So there's a couple of issues if we try to combine ACCORD with SPRINT, and the very first quick question to any clinician would be, do you believe that a person with hypertension without diabetes but has other cardiovascular risk factors, do you believe that that's the same kind of person as somebody with hypertension and diabetes? And do you think hypertension control would work in a similar way in these two populations? And I think many clinicians would right off the bat have concerns that these are quite different populations, and that hypertension may very well affect these populations differently, and the control of hypertension could be potentially lead to different outcomes in these populations. So I would have concern combining SPRINT with ACCORD. The other issue is that if we just look at the outcomes that drove SPRINT's positive results were different than what we saw in ACCORD. So, for example, ACCORD, we see strokes significantly reduced, but in SPRINT we don't see that. We see stroke being reduced, but not statistically significantly. So, SPRINT, we saw, for example, a big impact on heart failure, and that was not statistically improved in ACCORD. So these are things that, again, that would make me concerned that control of blood pressure, at least in these two studies, seem to have different effects on the outcomes. And again, that would make me concerned about trying to combine them into a single meta-analysis.
Doreen, is your microphone working now? No, can't. All right, we're still not on. Sheldon, any comments?
No, I agree with Phil. An unusual occasion.
Yeah, I think the thing that was most striking to me was the significance. The only thing that was statistically significant, the way that the ACCORD data was analyzed, was the stroke outcomes, and that's the one outcome that I thought would be positive in SPRINT and wasn't. So it quite sort of a strange discordance there. I guess we'll jump to the next question. There was a recent meta-analysis, and I don't know if you've had a chance to look at it carefully, but it was looking at treating people living with diabetes who have blood pressure levels less than 140, and suggested that there actually might be some potential harm in that setting. I know that Doreen had some very specific comments about that, but we're just trying to get her microphone going. But do either of you guys have anything to say about that?
Phil, do you want to go ahead?
Well, the strength of your belief in those results depends on the strength of your belief that these trials could be combined. And again, I think the criticism against that particular meta-analysis is, again, relates to the heterogeneity of the studies. And I think that it fails, again, the face value test. Some of the trials were studies that looked at different levels of blood pressure, which on the surface of it, maybe those could be combined. Others were organ protection studies that did not study particular blood pressure targets, but rather involved the use of antihypertensive medications for organ protective effects. And you know, that's quite a different type of clinical trial. So yes, it was a clinical trial on diabetes. Yes, they involved antihypertensive medications, but these study designs, they don't lend themselves well on the surface of it to combination in a meta-analysis. So my own thought on that particular paper was I wasn't sure that that these studies should have been combined in the first place, and so I didn't put a lot of weight on either any positive or negative results.
Bill, I completely agree with you. And George, I wonder what your thoughts are as Doreen is rebooting her computer. But I was reading through Doreen's comments last night, and I agree completely that most of the studies in the meta-analysis were not blood pressure lowering studies. They were studies of cardiovascular risk reduction, and the blood pressure lowering was sort of parsed together from bits and pieces of strata. And most of the data comes from achieved blood pressure results versus targeted blood pressure results. So it's the kind of meta-analysis that makes me really uncomfortable. Now, it goes against my personal beliefs, so maybe that's another reason why it makes me uncomfortable. And it bothers me that when you include the ACCORD study and a whole ton of other studies that weren't anywhere near as methodologically sound, it pulls the ACCORD study in the wrong direction. For example, ACCORD has a nice reduction of stroke, and it's statistically significant, and that is washed out in the meta-analysis. And if you had enough bad studies against a really good study, it seems to cancel out the good study, the study with really strong internal validity.
Yeah, I agree with both of you. I think a couple of thoughts. Many of the studies in that meta-analysis were not studies of blood pressure of hypertension patients, and they were looking at other things, cardioprotection and that type of thing. But I think that one of the potential messages of HOPE-3, which was just published, is that you probably need a certain amount of blood pressure lowering in order to achieve benefit. And in HOPE-3, a blood pressure reduction of 6 millimeters of mercury systolic was not associated with a significant reduction in outcomes in patients with some cardiovascular risk. But again, most of the patients in HOPE-3 were not hypertensive patients, and so I think it's a combination of both the type of patient in terms of their baseline blood pressure level, and I think that most of the patients in ACCORD would have been considered to have been hypertensive at baseline versus treatment of patients who are not hypertensive. And I think the idea that if you take a non-hypertensive patient and try to lower their blood pressure, you may not see much of an effect, especially if you don't treat them very aggressively, is not really a surprise. Doreen, I see you're up. Is your microphone working?
I think so.
Yay.
Yes, it is. Perfect. Any comments so far from the conversation?
And I apologize. Oh, sorry. I've had to pop in and out. So I think just a couple of things though that I wanted to add that I think that in relation to the first question was just that with respect to what can we take from SPRINT in terms of managing our patients with diabetes and hypertension. And I'd like to echo everything that Phil and Sheldon said. And I think that the simple answer, of course, is that because patients with diabetes were excluded, that we can't make any direct inferences from SPRINT to patients with diabetes. But at the same time, it's extremely hard not to consider patients with diabetes as being a high-risk population that we need to carefully consider. And just to echo what my colleagues have said is that historically, we have treated patients with diabetes to a more intensive target, and we have to look at the body of evidence to determine whether moving towards more intensive targets is ultimately going to be of benefit to those patients. And I think that the totality of the evidence for patients with diabetes is a bit murky, and I think that that's going to be a challenge for us going forward, is try to distill out what are the key messages and what are the key points of knowledge that we have great confidence about in terms of the benefit of these more intensive targets.
Great. Any comments on you had some good comments in an email on the meta-analysis looking at treating diabetic patients with baseline systolic blood pressures less than 140. Do you want to sort of go through that for us?
Yeah, so I think that certainly on the heels of Sprint, there was the Brewster meta-analysis that was published in the Lancet, so a very high-profile publication, and I think that it did provide a lot of, on the surface of things, some support to what the current targets or what the current trends were in terms of managing patients with hypertension and diabetes. And the take-home message of that meta-analysis, of course, was that there did appear to be at least a plateauing of benefit once you hit a systolic target of 140. And certainly also suggested that starting or initiating blood pressure therapy in patients that had systolics below 150 was perhaps of questionable value. I think that the key things we have to consider when we're looking at that sort of evidence, meta-analytic evidence, we have to remember what were the inclusion criteria for the studies in that review. And while the studies that were included in that Brewster review all were, they had trial data on patients that had diabetes. They had trial data that looked at the potential value of antihypertensive treatment in patients with diabetes. What they were not were trials that specifically evaluated specific systolic blood pressure targets. So while we were looking at potential benefits of blood pressure lowering, these trials were not designed to look at specific targets. So we're really making indirect inferences from these trials when we meta-analyze it and try to draw conclusions regarding targets. I think the other thing we have to remember in the trials that were reviewed is that the primary outcome wasn't always cardiovascular disease. It may have been looking at progression of renal insufficiency in patients with incipient nephropathy. It may have been looking at progression of retinopathy as a primary outcome. So again, some of these very important outcomes that they were looking at in terms of cardiovascular or all-cause mortality were secondary outcomes. So I think it's important to remember that while Bernstein and colleagues reviewed a body of data that did have information on patients with diabetes and did have information on potential benefits of blood pressure lowering, it was done in a context that was not to evaluate specific targets. So I think that has to be kept in mind when we look at that review. And I think that's very, very important. And I think that the other issue is that what was reported was the results of a stratified analysis. So a number of studies with similar characteristics were put into different strata. And specifically in this study, they were looking at outcomes based on patients' baseline blood pressure and their achieved blood pressure. And so what we're looking at in each strata is basically a composite mean of all of the mean baseline blood pressures or all of the mean achieved blood pressures in each of the trials within that review. And when that happens, what we're looking at is very aggregated data, and then it becomes very challenging to draw conclusions about individuals when we're looking at large aggregated means. So I think that there's a couple of things that we just need to really keep in mind when we're looking at that Brewster review before we start extrapolating to individuals.
Great. That's super. There is a question from the audience, and I'd like to remind listeners that if you would like to put a question to our panelists, you can do that by emailing it to info@hypertension.ca. So if you have a question, so the question from the audience, ACEs or ARBs are often recommended for patients with diabetes just for renovascular protection. What strategy do you use if the blood pressure is already close to 120/80? Do you use a lower dose of the ACE or ARB? Is it okay to go with no ACE or ARB, or you know what? How do you? And then I guess the other question is, do you try to go for a target dose of the ACE or ARB based on whatever trial showed the renal protection? Any comments on that?
So I'll take a whack at that. So the Canadian Diabetes Association has a priority system for what the clinical priorities are, and general vascular protection actually sits over top of hypertension in that pantheon. And part of general vascular protection, part of it is lifestyle management, part of it is things like smoking cessation, lipid control. But one of the items in there is RAS blockade, either an ACE inhibitor or an ARB, as a general vascular protection agent, and not specifically for people for control of hypertension. So most people with diabetes, because of their degree of cardiovascular risk, would qualify for an ACE or an ARB for general vascular protection, even before we get to a discussion of blood pressure. And that would be true for normotensive people with diabetes. They would still benefit from both a cardiac and a renal perspective from a RAS blocker. So I would put that as a priority for a person with diabetes. And as for the dose, on the cardiac side, we know that the full therapeutic dose of ACE inhibitors, for example, produce vascular protection and reduction in cardiovascular events, improvement in cardiovascular survival. Those were studies like HOPE and Europa that used the full dose, so 10 milligrams of ramipril, 8 milligrams of perindopril. There were other studies, sub-studies, like diabetic, where smaller doses of ACE inhibitors were used for the purpose of vascular protection, and those studies did not show any benefit from low-dose ACE inhibition as a general vascular protection strategy. And so from the vascular protection standpoint, we aim for the full dose, the full therapeutic dose of the ACE or ARB that has been selected. And on the renal side, we see also the same type of thing, that we see it in terms of progression of kidney disease in people with diabetes. In the renal trials, we saw a dose-dependent benefit. So going to the half dose of an ARB slows progression of nephropathy. Going to the full dose of the ARB slows it even further. So I think for most people, for end organ protection, we would be using a RAS blocker, and we would be trying to get them to the full therapeutic dose.
Great. Maybe we'll just do one. We're coming to close to the end of the time, so I'm just going to give you my question, which I thought, I don't know the answer to this question, but I thought maybe I'll read it off, and maybe we'll get Doreen's opinion since she hasn't had a chance to add to the earlier parts of our discussion. But patient with a body mass index of 35 with a glycated hemoglobin of 7%, who is considered to be diabetic but on dietary management, not taking medications for diabetes. Patient otherwise meets the sprint inclusion criteria. At what threshold and target would you recommend when their glycated is 7%? And then if the patient loses weight and the hemoglobin A1C goes down, at what point would you consider moving to a sprint threshold or target? Doreen, do you want to take a crack at that?
Sure. And I have to congratulate you on that question, because when I reviewed it, it was one of the ones that made it did make me sort of think very, very carefully about how we have to approach and how we have to discuss the evidence that we have regarding blood pressure targets in patients that have diabetes and patients that are otherwise at high risk. So I think the one thing this question also really sort of highlights is the importance of trying to really be objective about our evaluation of cardiovascular risk in our patients. So in this particular case, when a patient does have a hemoglobin A1C above the diagnostic threshold for diabetes, they should be treated as we would recommend for patients with hypertension and diabetes. So at the beginning of this clinical vignette, when the patient has an elevated BMI and has a hemoglobin A1C, my current practice would be to target a blood pressure of less than 130/80. Having said that, if I started one single agent and their blood pressure went down below 130/80 and they were tolerating it well, I don't think I'd be quick to back off treatment if they were tolerating that blood pressure well. But my target would be 130/80. If in time, and they, as we do for our patients with hypertension, as we do with our patients with diabetes, I would be supporting the adoption of several healthy behaviors. And if they were adopting and they were doing well with that element of their treatment, and were successful in losing weight, then and their A1C went down and they were doing well in terms of maintaining their blood sugars off treatment, then again, I think it's important to reevaluate the patient holistically and look at what their global cardiovascular risk is. I mean, the reality is that their BMI's gone down, and their hemoglobin A1C has gone down. Their blood pressure has also probably gone down. Their lipids may also be have improved as a result. So it's possible that their overall cardiovascular risk is likewise gone down. But assuming that those things were held constant, the only thing that's changed is diabetes. Then again, if they qualified for sprint, but now their diabetes was essentially in remission, I think I would look at intensifying their target, because this patient, while they're doing a wonderful job in terms of reducing their cardiovascular risk, there's still someone who has residual risk that I think that we need to be mindful of. So I think in this individual, I would initiate with a target of 130/80. If their diabetes responded nicely to lifestyle intervention, but their other cardiovascular risk factors remained and warranted or made them eligible for a sprint target, I would likely look at intensifying therapy if they weren't already at a target of 120.
Great. Any comments from Phil or Sheldon?
Here, I'll add that many of my patients that match your description, when I start them on therapy and target a blood pressure of less than 130 systolic, end up awfully close to 120. So I would likely just continue them on that therapy. As they lost weight, their blood pressure would come down, and they would achieve that less than 120 result that we would want in a sprint patient as well.
Phil?
I completely agree with everything Doreen said too.
I like those two answers. I don't have anything really to add to that, I don't think.
Great. Okay, well, I think that's it for this session. Thank you all for coming, and thanks to our sponsors for supporting this activity, and hopefully we'll be able to do a lot more of these and get some good exchanges going and make this work for our audience. So for accreditation purposes, there is an evaluation that you can fill in at hypertension.ca/sprint evaluation. And certainly if you have any feedback for us on even the format and how we're doing the technology, we'd be happy to hear that. And we apologize for Doreen's microphone. We'll make sure it doesn't happen next time. Anyways, thanks very much, everyone.
Thanks, George.
Thanks, George.
Thank you, George.